Thanks for joining us online. We're about to start in less than 2 minutes. As you can see, the first part of a 4-part mini-series on the exciting topic of serosurveys. We're doing this with the International Vaccine Access Center from Johns Hopkins Bloomberg School of Public Health. And we'll see you in just under 2 minutes. If you have already questions and comments, go ahead and type them in. We'll see them right away, and we'll share them with our panel today. See you soon. Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki from the Geneva Learning Foundation today with Charlotte Mbu and our guests. We're going to be discussing the topic of serosurveys, the first of a 4-part mini-series. How are you doing, Charlotte?
I'm doing great, Reda, and it's always a pleasure to have guests that are coming to talk about topics that are of interest to our immunization community.
Wonderful. So we've already got some comments. Kiyu Omers F from LinkedIn says, good initiative. Thank you, Kiyu. I hope you have some good questions for us. We'll be doing the Q&A first and then moving on to the questions. Dr. Subhadip says, great to be a part of this. And indeed it is. Thank you, Subhadip, for joining us. Imam Wada Bello says, nice joining you from Kano, Nigeria. And then Iyad Abdelgadir also sends his greetings. All right, let's jump in. So we have with us Andrea Carson and Bill Moss. So Andrea, we're going to start with you. Can you introduce yourself and can you tell us where you work, what do you do, and when was the first time you heard the word serosurvey?
Sure. Hi, I'm Andrea Carson, and I'm a researcher at the International Vaccine Access Center in the International Health Department at the Johns Hopkins Bloomberg School of Public Health. I work with Bill Moss here on a project called Strengthening Immunization Systems Through Serosurveillance. And I actually first heard the term serosurvey when I was working at CDC in the Global Immunization Division. I worked on polio eradication and had done a number of vaccination coverage surveys and sort of heard the term serosurvey floated around to measure progress towards eradication, but I didn't really know what it was, and I didn't work on them until I came over to Hopkins.
Great, thank you. So a quick question. So Bill Moss, you are the director of the International Vaccine Access Center, or IVAC. Can you tell us when was the first time you heard the word serosurvey, and what does IVAC do exactly around this topic?
Yeah, so thanks, Reda, and welcome everyone. So I first heard about serosurveys early in my research career. I started working on measles and understanding the pathophysiology of measles in Lusaka, Zambia, about 2 decades ago, and I did my first serosurvey, I think, in about 15 years ago. So it was in the context of understanding immunity to measles that I first heard about the term serosurvey, and we can talk more about that in this mini-series. So IVAC, the International Vaccine Access Center, is a center based at the Johns Hopkins Bloomberg School of Public Health. We celebrated our 10th anniversary last year, and our mission is to accelerate global access to life-saving vaccines through the development and implementation of evidence-based policies. We've been working on a project funded by the Bill and Melinda Gates Foundation, as Andrea alluded to, called Strengthening Immunization Systems Through Serosurveillance. And this project's based in both Zambia and in India. It's focused on measles and rubella serosurveys, but obviously there are broader implications. And we're really trying to understand both the feasibility and utility of serosurveys, particularly for how serosurveys can guide immunization programs, and we'll talk more about that.
Great. Thanks, Bill. So IVAC has produced new digital resources on serosurveys. I believe we actually have the link. Can we share with folks who are watching the first part of this 4-part miniseries and give them sort of early access? Would that be okay with you? All right. So the link is serosurveytools.org, and we're not going to go through it now, but I invite you, if you're looking at this right after the this first part of the mini-series, you will be able to go and visit serosurveytools.org. Great. All right, let's dive in. It is Charlotte who is going to ask you really a set of questions, looking at one aspect of serosurveys and digging in to really the essential questions. And then we'll turn to the folks on Facebook, LinkedIn. Facebook, LinkedIn, Twitter, and YouTube, who are following, and we have viewers joining from all over the world. So Charlotte, over to you.
Thank you very much, Reda, and hi, Bill and Andrea. It's so great to have you with us today, and I'm looking forward to getting you answer my questions. Now, the very first question I really want to hear, and Reda, just to say, the first time I heard the word serosurvey was earlier this year. So before COVID, I had never heard that word. So what is a serosurvey? Bill or Andrea?
Sure, I can answer that one. Serosurveys are studies that test bodily fluids, usually blood, hence the sero part, but it can also use things like oral fluid to estimate what proportion of the population has been exposed to a pathogen. So as you mentioned, now there are a lot of serosurveys underway, for example, for SARS-CoV-2, to look at what percentage of the population has been exposed. And that could be exposure due to either vaccination or natural infection.
Okay, and why is it useful? What are the uses of serosurveys? Why should they be conducted?
Sure. They're useful because they can help to estimate, as I mentioned, sort of what proportion of the population has been exposed. But conversely, that can also tell you how many people might remain susceptible to that pathogen. They can be particularly useful for detecting things that are asymptomatic infections, as again is the case for SARS-CoV-2. And for vaccine preventable diseases, which as Bill mentioned, we focus on measles and rubella, they can also help us to identify which age groups should be targeted for vaccination. If you're doing a vaccination campaign, they can help you evaluate the impact of that campaign. You could monitor the duration of immunity, see if you need a booster dose kind of later on based on how the population ages, and help monitor progress towards elimination. And when seroprevalence is correlated with immunity or protection from a pathogen, serosurveys can help you to start estimating herd immunity thresholds and identify immunity gaps, which I think we'll talk about a little bit more.
And when you talk about herd immunity, what do you mean? When we think about the herd, we think about animals and all of that, but within the context of immunization, what does that mean and what is an immunity gap?
Yeah.
Maybe Andrea, I'll take
Yeah.
that if that's okay.
Go ahead.
Yes, please,
We've,
Bill.
we've been talking about herd immunity a lot, obviously, with the COVID-19 pandemic, and so a lot of people have become familiar with this term. But I think you're right, Charlotte. Maybe a lot of people don't understand exactly what it means. It actually has its origins in veterinary medicine, and that's why the term herd immunity is used. It was originally used to describe immunity about a contagious abortion disease in cattle. So that's why we use that term, and it's kind of stuck. And over the years, people have resisted using the term herd immunity because of the implications, as you said. And some people talk about community immunity or community protection. But basically what it is, conceptually, it is when enough people in a population are immune, it just makes it very unlikely that an infectious individual will come into contact with a susceptible individual and you'll get transmission. And so that's the idea that when a certain proportion is immune, basically the infection will die out or the outbreak will die out. And that's why it's such an important concept, particularly for vaccine preventable diseases, where we try to build up this quote herd immunity through vaccination.
So, Bill, can you give a few examples of some vaccine preventable diseases that could actually be prevented through herd immunity?
Yes. So there are many, but I think the classic examples are measles probably and rubella. So the way we think about it, there's a very simple, we think about it in terms of what's called the reproductive number, which is the average number of infected of cases that will develop with a single infectious individual. And it's a measure of contagiousness. And using that number, that estimate of the basic reproductive number, we can estimate, get a rough guide on what the herd immunity threshold is. So what that means is that the more contagious a pathogen is, the higher the level of herd immunity that's required in order to interrupt transmission. So take measles virus, which is one of the most contagious viruses we know. That has a reproductive number of on the order of 12 to 18, meaning in a completely susceptible population, a single infectious individual could infect up to 12 to 18 other people. Based on that number, we estimate that the herd immunity threshold for measles is between 93 and 95%. That's very high, and that's really why measles elimination and eradication are so challenging. Now, for SARS coronavirus 2, the estimated basic reproductive number is on the order of 2 to 3. So then maybe the herd immunity threshold's on the order of 50 to 66%, basically. Now, there are a lot of simplifying assumptions in that little formula that I use to calculate herd immunity threshold, but that gives us a rough idea, at least of the relative differences, let's say, between measles and SARS coronavirus 2 in terms of herd immunity.
Thank you very much, Bill. I may want to turn to Andrea, just in line with what you just said. Is it possible, can immunity gaps be identified using vaccination coverage surveillance or vaccination coverage data surveillance? And why do we really need serosurveys? If we can just look at the coverage and say if coverage is not up to 90%, then it means there's an immunity gap. Why do we really need serosurveys to do that?
Sure. So like you said, you can use that vaccination coverage to start to estimate what proportion of people might be vaccinated. But when you give a vaccine, that doesn't necessarily cause an immune response in all children or adults. But for that reason, you might still have part of the population that even though they've been vaccinated, they're not actually immune yet. And so you won't see that gap if you're looking just at vaccination coverage. Versus if you're doing a serosurvey, it's a more direct measurement of population immunity, and you'll be able to catch who is actually still remaining susceptible in your population. Similarly, if you use surveillance data, you are capturing obviously who has been infected, but we know that often surveillance data underestimates the true number of cases because those are only the ones that are actually being reported to the surveillance system. So you wouldn't be able to catch all of the population that still remains susceptible. So because of those two things, serosurveys are a better measurement, and you're able to capture the people who have been protected either through vaccination or through natural infection. So it really gives you a clearer picture of your population immunity.
We're going to go check in on the folks we're following on Facebook, LinkedIn, Twitter. We've got many messages and comments, mostly people introducing themselves. Remember, you can actually ask your questions and comments. We do have the following comment from Iyad Abdelgadir from Oman, who says, in Oman, we have already completed 4 cycles of serosurveys, specifically for SARS-CoV-2. Informed decisions are now taken, also finalizing our action plan for COVID-19 vaccine, mRNA vaccine, progressing to cover priority groups. I don't know if Bill or Andrea, you'd like to comment or respond to that in any way before we go to the next and final set of questions.
Yeah, maybe I'll thank you, Rita. That's a really excellent comment, and we're very glad to hear that serosurveys are being used programmatically in Oman, and they give a nice picture of the proportion of the population that's been exposed to the virus. And as the listener said, can be used to guide the immunization program. So that's really nice to hear.
Great. Back to you, Charlotte, for the next set and final set of questions.
Thank you very much, Reda. And Bill just went ahead and answered my first question, because I was about to ask that how the serosurveys help immunization program decisions. So I'll just get on with the next question. You see, how can serosurveys inform decisions around when and where there is need for MCV campaigns?
Yeah, so I can take that one, Charlotte, and in a number of ways. But I think, as Andrea said earlier, serosurveys can help identify immunity gaps that aren't really recognizable with routinely collected data, whether that's vaccine coverage data and case-based data. And serosurveys are helpful in a number of ways. One is that they can identify these immunity gaps, particularly in older individuals, that can be very difficult to identify using vaccination records or recall, for which we all know there's a lot of uncertainty around. It can also identify immunity gaps potentially that may even have been filled by natural infection that wouldn't be captured through routine immunization records. And so it can help, I'll say in short, Charlotte, it can help identify age-specific immunity gaps. It can help identify geographic areas where there are immunity gaps and where the vaccination coverage data may be poor. And it can also be used to identify immunity gaps in specific subpopulations. Let's say, for example, in HIV-infected individuals that might otherwise go unrecognized.
Thank you very much, Bill, for answering that question. Now, Reda, I don't know, I'm sure your eyes are on our platforms looking out for questions, because I have one last question I'll start with Andrea. It has to do with SARS-CoV-2, because you said earlier that with SARS-CoV-2 and the COVID-19 pandemic, there's a lot of serosurveys that have been going on here and there. So my question is, how can data from SARS-CoV-2 help be used to inform the pandemic response and maybe the rollout of a COVID-19 vaccine?
And this is specifically data from SARS-CoV-2 serosurveys, of course.
Yes, definitely, Reda.
Yeah, so I think the listener from Oman started to talk about this. I think serosurveys can be really useful for SARS-CoV-2 to help us identify really the true extent of the outbreak, to look at the geographic distribution, and maybe identify hotspots or particular groups that have been hit hard by the SARS-CoV-2 outbreaks. They could also give us better surveillance data to get a better understanding of how many cases there have really been because of underreporting in setting up the surveillance systems and because not everyone gets tested. And I think Bill alluded earlier to what we think the herd immunity threshold might be for SARS-CoV-2. So a serosurvey can help us monitor progress towards that herd immunity threshold, particularly, as you mentioned, as the vaccine rollout happens. We'll want to continue to monitor and track because now the surveillance data will only tell you who's infected and the vaccination data will only tell you who has been vaccinated. But to get the full picture of who is immune, the serosurvey can help track that a little bit better. I don't know, Bill, if you have anything to add.
Yeah, no, I think, Andrea, that captures a lot of it. We know, particularly with SARS coronavirus 2, that there's a lot of asymptomatic infection. So as Andrea said, it really gives a much truer picture of the extent of the outbreak in a particular community, more so than reported case data. And that's really important for understanding, for example, the infection mortality rate, what proportion of individuals who are actually infected die. You really need that denominator data. And then, as Andrea said, as vaccines are rolled out, we can track that progress toward herd immunity. Although I'll say that's going to be quite some time from now, because it's going to be a long time before we have enough vaccine doses to really reach the global population.
Okay, thank you, Bill and Andrea. So if I got you right, it means information from SARS-CoV serosurveys can also help to prioritize which communities or which age groups should receive the vaccines first. If I could use layman's language, is that it?
Well, I think, Charlotte, at least what we're seeing in the United States is that the priority groups are healthcare workers and residents of long-term care facilities. And, each country will have to make their own decision as to what are the priority groups when they have limited number of doses. And it may be that serosurveys may not inform that early decision, but I think it'll be more important going forward as more vaccine doses become available. And it certainly helps tell individual countries and EPI programs where the outbreak has been most severe within their country.
Thank you very much, Bill. Reda, any questions from our viewers this afternoon?
All right, thank you, Charlotte and Bill and Andrea. We've got a comment from India and then a question. And I think if we're over time, but it'd be good to unpack that question. So first of all, Subhadeep says, in India, we're planning for a third round of serosurvey by ICMR. I'm going to ask you, can you clarify what is ICMR and how it fits in? Andrea or Bill, quickly.
Yes, so ICMR is the Indian Council of Medical Research. It's really the government medical research arm, and a fantastic organization. We at IVAC work very closely with ICMR on our serosurveys in India, and their institution, the National Institutes of Epidemiology, has really led these first two rounds of serosurveys for SARS-CoV-2 in India. And as the listener said, are planning a third one. And doing these serial serosurveys are really valuable because you get to see, they're really informative in telling you on the progress of the epidemic in a particular country. You can really see how fast it's spreading, not just how widespread it is, but how fast it's spreading through these serial serosurveys. So very important work led by ICMR in India.
Great, thank you, Bill. And then we have this comment that I'd like you to unpack, or actually a question. So from Rajendra Kumar on Facebook, who says, as we know that vaccines against COVID-19 are now available, do we need to go for serosurvey post-introduction to no seroconversion sort of thing? So I'm not sure I fully understand the question, but you seem to, Bill, please.
Yes, I mean, I think, as Andrea alluded to earlier, serosurveys might be helpful in really tracking progress toward a purported herd immunity threshold. But the phase 3 trials of these vaccines really show us the protective efficacy of these vaccines. So I don't think at an individual level we'll need to look for seroconversion after vaccination. Hopefully we'll know from the phase 3 trials whether or not, what proportion of individuals really respond to this vaccine. So I don't see that being done to monitor individuals' responses to the vaccines.
Great, thank you, Bill. As we're getting close to wrapping up, I just want to point everyone to the special event that you can watch at any time on the website learning.foundation. Want to remind you also that this is only part 1 of 4. So every day at this time, you'll be able to tune in on LinkedIn, YouTube, Twitter, Facebook, whatever is your preferred platform, and hear more reliable information about serosurveys. We do have, however, more comments and questions flowing in. I suggest we'll also be looking at any questions we didn't get to and sharing them with the IVAC team so that they can answer them tomorrow. I'd like to take one last question. Mercy Onu Peters, who says from Facebook, how can serosurveys help you to detect who has taken COVID vaccine?
The vaccine induces antibodies to the spike protein, the surface protein of SARS coronavirus 2. But people who have natural infection also have antibodies to that spike protein. So right now we don't have a way to distinguish, and this is actually true across almost all pathogens. We don't have a way to readily distinguish in a serosurvey whether those antibodies, those IgG antibodies, are due to vaccination and immunization or due to infection with the natural pathogen. So that's still an area where more work needs to be done. We at IVAC are working somewhat in this area, but distinguishing vaccine acquired from natural immunity is still challenging in serosurveys.
Thank you, Bill. And we have this comment from Green Sadru, who says, hello, everyone. Really, it is high time to have serosurveys given various challenges to confirm public immunity. I see you nodding, Bill. Would you like to, again, explain and provide the context?
Yes, we recognize that serosurveys can be very challenging to implement. They can be expensive, and we're going to talk later in this series on how best to implement serosurveys and what the challenges are. So we're not naive to the fact that these are not trivial to pull off and to pull off accurately. But we also agree with the listener that these can be very valuable tools to guide immunization programs, to understand the extent of infection with a pathogen such as SARS coronavirus 2. And what we're trying to do, and would like to work with your team here, Rada, and all the listeners, is to figure out how best to use serosurveys to guide immunization programs and pandemic responses, so that so that they're not overwhelming, but that they provide very useful information programmatically.
Great. All right. So we are reaching the end of this episode, but remember that this is only part 1 of 4. So for television fans, if you work in immunization, this qualifies as must-see television, and we invite you to tune in tomorrow. Obviously, we're exploring how we can do things a little bit differently than the 60-minute webinar. I do see a question from Raimi Morufu. When exactly are African countries going to get the COVID-19 vaccine? That's technically out of the scope of this discussion, but tomorrow we have another workshop that I'm showing here on screen with Anne Lindstrand. So she is WHO's co-lead for COVAX, the vaccines pillar of the ACT Accelerator, and she may be able to probably one of the best people to provide the best available answer at this time to that question. Just want to thank everyone for having joined us. If you'd like to know more about the topic of serosurveys, we do have this special event which was done with IVAC over the summer. It's now being run every 4 hours, so you can go to learning.foundation and find this this event. And if you've been waiting, if you've been watching this far, if you've gotten this far to the end of this episode, here is something that I encourage you to visit right after we finish. I'd like to ask the IVAC team, what are we looking at? What is this serosurveytools.org is the address. What are these serosurvey modules? Could you help us understand what viewers may go to find there?
Yeah, so thanks, Rita. And what we've been doing at IVAC, as we've been, learning lessons from the serosurveys we've been conducting, and from many of our colleagues and other sources, particularly at the World Health Organization and CDC, we've been trying to collate in a web-based format some guidelines on conducting serosurveys. These are not exhaustive yet. They really focus on kind of issues around the specimen collection, things that are really unique to serosurveys rather than surveys in general. Although some of those issues are really important, such as sampling strategies. So what we've put together is a series of modules on a web-based platform and some tools that we used in our serosurveys, such as forms and Excel spreadsheets to check data, and are really making these available to the public health community and the immunization programs so they can learn more about actually the conduct of serosurveys and basically leverage and modify some of the tools and documents that we've created.
Great. Thank you, Bill. So I invite you, if you've watched this first episode, one is to join us tomorrow for the second episode. Second is to go to serosurveytools.org. And then if you'd like to know more, if you did not or have not seen the special event that we did this summer with IVAC, you can find that on learning.foundation. For Abidemi Olatunde, who wants to know if people taking the coronavirus vaccine are having negative effects on them. So these are the kinds of questions we'll be dealing with tomorrow in the event with Anne Lindstrom from the World Health Organization. Even though I'm kind of itching to ask Bill that question, that's really outside of the scope of this this mini-series. So once again, thank you. I'd like to ask you to give a big round of applause to our presenters. And that's not bad. Yeah. All right. And Elvira Hassan, we haven't heard from her today, but she will be, I believe, talking to us tomorrow about how to actually conduct community-based serosurveys. Elvira, would you like to give us a teaser? What will people learn tomorrow by joining tomorrow's second episode? Oh. All right, it was not planned that we would ask Elvira. I'm not able to hear her, but you'll find out. You'll have to join tomorrow to find out. Great. Let's have more applause together with the music. I see applause in the comments. Thank you, Edmond Osei Kwaye, Abdul Wajid Kandaudzi, Abidemi Olatunde. Hope you'll be attending the workshop tomorrow, and Amel El Taher. Many of you are regulars on these live streams that we do across the different platforms. Thank you for joining us. Thank you for your trust, and look forward to seeing you tomorrow for episode 2. To those of you who are just joining the stream, we're counting down in less than 4 minutes. We'll be joining Bill Moss and Elvira Hassan, who'll be discussing community-based serosurveys and exactly how to conduct them. So stay with us. We'll be there. Let me check the countdown in 3 minutes and 20 seconds. See you soon. If this is the first episode that you are joining, this is part 2 of a 4-part series, so I strongly encourage you to go and check out part 1. Part 2 today will make more sense. You can find it if you're watching us on LinkedIn. Just look on the Geneva Learning Foundation's LinkedIn page, and you'll find all 2 parts today, and then parts 3 and 4 tomorrow and Friday. If you're on Facebook, look on our Facebook page, Digital Scholar, and you'll find it. You'll find part 1 there. If you're on Twitter or YouTube, the same applies. Just find our page, and happy to welcome one of our most regular scholars and supporters, Dr. Tanushree Mandal, connecting from West Bengal, India. A prolific commenter, always with good questions and comments. So Tanushree, thank you for joining us, and look forward to reading and sharing your comments and questions during this session. See you in 1 minute and 30 seconds. Here we go. Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki, and this is part 2 of a 4-part mini-series we're doing with the International Vaccine Access Center. In the room with me, to my right, is Bill Moss. He's the director of the International Vaccine Access Center. Welcome back, Bill, for part 2 of this series. The International Vaccine Center. Can you give us a recap? What is it for those of you who missed part 1?
Yeah, so what we're doing here is that the International Vaccine Access Center is engaged in conducting serosurveys, largely for measles and rubella in Zambia and India, and we've learned a lot, and we want to share some of our experience and findings. We know many serosurveys are being done for SARS coronavirus too, so that's the purpose of this these mini series.
Great, thank you, Bill. And today we're introducing a new character to the cast of this mini-series, Elvira Hassan. Kindly introduce yourself. Where do you work? What do you do? And when was the first time you heard the word serosurvey?
Thanks, Rita. My name is Elvira Hassan, and I work as the India Research Program Coordinator at IVAC. I'm based in New Delhi, and I've been working with Bill and his team at IVAC on measles and rubella serosurveys, primarily focused in India. I first heard of the word serosurvey about 3 years ago when I was a student at the School of Public Health, probably from Bill, and I was very interested in infectious diseases and surveillance. So since then, I haven't looked back. Thank you.
All right. So we are live streaming this series to LinkedIn. So if you're watching us on LinkedIn, let us know you're there. Leave a comment. We can see, and we'll be sharing your comments. Let us know what city and country you're connecting from, and if you have experience in serosurveys. If you're watching on YouTube, the same. You can leave us comments. We'll also see them and be able to share them with Bill and Elvira. Twitter is on Digital Scholar X. You can find the stream there. On Facebook, it's Digital Scholar is the page of the Geneva Learning Foundation. Now, before we go any further, I want to tell you a little bit about what we've been up to. This is a very busy week at the Geneva Learning Foundation, and specifically the COVID-19 Peer Hub. So this morning we had a workshop for the first time working with Dr. Anne Lindstrom from the World Health Organization headquarters, looking at what it means for immunization staff working in countries to be getting ready for the introduction of COVID-19 vaccine. And there was a workshop we did not think we would be able to do in 2020. So that was quite an exciting moment. You can find the recording right below this workshop. If you scroll down, you'll find the recording and still be able to leave your comments and questions. Tomorrow, we're connecting with Professor Heidi Larson. She'll be joining us here again on our page, on the page of the Geneva Learning Foundation. You'll be able to find the live stream, comment, ask questions, participate to discuss this critical issue of what makes people have confidence that a vaccine works, that it is safe, that it's effective. That's what we'll be discussing with Heidi tomorrow. Right now, we're kicking off the second of a 4-part mini-series, and we're with Elvira Hassan and Bill Moss, as well as Charlotte Mbou. Welcome, Charlotte. And I believe you're going to take it from here with the questions. So we'll be looking at your questions first. I want to acknowledge a few of the people who are joining us. So Samuel from Liberia, welcome to you. You've just joined us on LinkedIn. Dr. Pierre-Hubert Ngoy Kamona from Lumumbashi in the Democratic Republic of Congo. Brima Barrow from the Gambia. Jyoti Lande from India. And of course, our very own Tanushri Mandal. Charlotte, over to you.
Thank you very much, Reda, and greetings to everyone that is joining us for this day 2 of this mini-series. So I've just turned towards Bill for my first question of today. So Bill, what are the essential components of a serosurvey?
Yes, thank you, Charlotte. And what we're going to be talking about in this part 2 are what we call community-based serosurveys. This is where we go into the community, often to people's houses, although it could be at a central location, and conduct a serosurvey. So there are really 3 essential phases in a serosurvey. There's the data and specimen collection, there's the laboratory assay, and then there's the analysis and interpretation. And we're going to focus today at a very high level on the data and specimen collection. So the components here, in terms of thinking about how to conduct a community-based serosurvey, the first thing is obviously to define the serosurvey objectives. This can be, what question do you want to answer? As Andrea Carson and I talked about in part 1, there are a number of uses or purposes of serosurveys. So you have to be very clear about what your research question is. Is it to estimate seroprevalence in certain age groups or geographic locations? Is it to classify a population? Do they have high, medium, low levels of seroprevalence. We can compare seroprevalence estimates across different subgroups. Say, for example, something I've done a lot, HIV-infected children and HIV-uninfected children. And if you do serial cross-sectional serosurveys, you can actually monitor changes over time. So the first thing is defining the research objectives. The second is identifying the target population, and that's driven by what the research question is. Third, we need to determine what our study design is, how we're going to actually do the sampling, and we can talk more about that. A fourth consideration or component is the specimen type. Do you want to use liquid plasma or dried blood spots or oral fluid? One has to choose the type of assay that they're going to do with the laboratory test to actually measure the seroprevalence. And one also needs a very comprehensive data management system to manage the data that are collected from the study participants and the laboratory assays, and be able to combine them for the analysis and interpretation.
Thank you very much, Bill. So, Alvira, this question is for you. What study designs can be used to conduct a serosurvey?
Thank you, Charlotte. So that's a really good question of what the different study designs are. There's various different ways you could categorize them, but one nice way to think about this is, study designs that use existing specimens that have already been collected for other purposes. So this includes residual specimens or those that have been left over that are available at a biorepository from other surveys, studies, and surveillance systems. You could also have leftover clinical specimens at a hospital site or at a lab. That's one type, and we'll be getting into that in some of the later sessions. But for today's session, for community-based surveys, it's usually in the designs that collect new specimens from survey participants. So this could be a standalone serosurvey that you do from scratch, or subgroups are also able to nest a serosurvey within a larger survey that is already being conducted for some other purpose, like a demographic health survey or a mixed survey.
Okay, great. How should the target population be selected, Bill?
Yeah, so as we said earlier, the target population is really going to be driven by what the serosurvey objectives are, what the research questions are. But broadly, there are two main considerations in thinking about the target population. One is, what are the demographic characteristics of the population of interest? Do I want to know the seroprevalence in a specific age group? For example, the age that was reached by a measles and rubella SIA or mass vaccination campaign. Do I have interest in a particular gender? Do I want to know more about a seroprevalence in women? So, for example, if one's interested in rubella seroprevalence and the risk of congenital rubella syndrome, one might particularly target women of childbearing age. One might also be interested in urban and rural differences. So there are a set of demographic factors that really help drive in part the target population. The second big question is the spatial scale that one is trying to estimate the seroprevalence for. Is one interested in district level seroprevalence estimates, provincial level estimates, national estimates? That's going to also help determine what the target population is. So kind of in summary, one has to consider the demographics that are needed, the demographic characteristics of the target population that will help address the specific research question, and then the spatial scale, the geographic scale on which one wants to have an estimate.
Okay, Alvira, who is potentially missed in a serosurvey, and why does that matter?
That's a great question, Charlotte. So I would say there may be different categories of populations you could miss in a survey. Some examples include hard to reach populations or hard to access populations that live in very remote locations, like in a rural area, or migrant groups, especially in India, who typically move from urban to rural areas seasonally. We also faced a lot of unavailability issues, especially in urban areas where you find a lot of locked households where families are away at work for very long hours. So we cannot get to speak to them and talk to them and get them into the survey. And of course, there are refusals. You get to the individual, you get to find the house, but they refuse to participate. But what matters is the why does it matter question. So while every survey, as you know, will have refusals and unavailability, and that is something that we accept in the study design, but it becomes a problem when you're systematically missing a certain group of people because that can introduce selection bias. And an example of this could be like if you're doing a serosurvey and you're trying to evaluate the impact of a vaccination campaign and trying to check what the population immunity was, if there's a hard to reach group of families who are missed in the campaign and then we miss them again in the survey, then the result we're getting out of the serosurvey are not representative, and maybe you're overestimating the seroprevalence, or the results may look better than they really are. So it really depends on who you're missing and how much.
All right, thank you very much, Alvira. My next question is addressed to you, Bill. Say, how should a specimen type be selected? What are the pros and the cons of different specimen types? You may want to add that.
Yes, this is really important, Charlotte, because collection of specimens is really obviously critical to any type of serosurvey. One needs a biological specimen in order to measure the IgG antibodies, or it could be other types of antibodies or even antigens in a seroprevalence survey. So one has to consider, how the specimen is collected. We can collect blood specimens through venous blood, through venipuncture. We can collect blood through capillary methods. We're using like a finger prick or a heel prick in a very young infant. We can also do serosurveys using oral fluid. There are IgG antibodies that are in cervicular fluid, and that's another way of collecting a specimen. We can also have different types of specimens, such as serum, in which the blood is allowed to clot, and one would need to centrifuge that down, and one can measure antibodies in serum. One can use anticoagulated blood and separate out the plasma. And a very common specimen type for serosurveys are dried blood spots. This is because of the ease in which these can be stored. They can be stored at room temperature. It's easy to transport them, and they can be much easier to handle in more remote communities than say a liquid blood specimen. So one has to consider also the type of assay that's being used and whether, for example, it has been validated for dried blood spots. In our experience, we sometimes get lower results when using dried blood spot, a lower measure of antibody level when using a dried blood spot compared to a liquid blood. So one has to make sure that the assay really has been validated for dried blood spot, and one needs a standardized protocol for eluting the serum off of the dried blood spot. Community acceptability is another very important consideration. We and many others have found that using finger prick blood collection is much more acceptable in many communities, although not all communities, than venous blood sample collection. One has to consider the volume of blood that needs to be collected. There are certain limitations, obviously, on how much blood one can collect through a finger prick. So there are a number of different considerations in terms of the type of assay that one is using, the community acceptability, the logistics about transporting and storing specimens that really drive the selection of specimen type.
All right, thank you very much for that answer, Bill. Now, my last question for this Q&A is addressed to you, Alvira. Say, are there resources or guidelines that are available to help guide those planning community-based serosurveys?
Thanks, Charlotte. So I would like to point to a resource that we've been working on, the serosurveytools.org, that we mentioned in the prior session. So there we've obviously compiled useful resources to help you plan and initiate surveys. But it would be important to mention some of the WHO resources that we use to design and plan surveys. And these include the WHO Vaccination Coverage Cluster Survey Reference Manual, which I think some in this network might be very familiar with. While these are mainly help you design vaccination coverage surveys, there's a lot of overlap between serosurveys and vaccination coverage surveys. And then also we have the WHO Measles Rubella serosurvey guidelines that look more into the serology side of things. So yes, you can see that on the screen there.
All right, thank you very much, Alvira and Bill. Now I'll turn towards Reda, see if there are any questions, additional questions that are coming up on our various platforms. Over to you, Reda.
Thanks very much, Charlotte. So there are many folks introducing themselves, and there are a couple of questions. So remember, we are looking at the comments. That is where you can ask questions, whether you're on Facebook, LinkedIn, wherever you may be. So let's see. We have Iyad Abdelgadir, who asks, any issues regarding non-specific cross-reaction of IgG tests? So that is question one. And then Dr. Tanushree Mandal wants to know, is venous blood collection very popular in serosurveys as people are quite apprehensive? Oh, and she says, Bill, you answered her question. All right.
Yeah.
Yeah, so maybe Reda, I can take the first question. There are situations in which cross-reactivity can be an issue. We don't see that in measles or rubella serosurveys, for example. Those are monotypic viruses. There's just a single serotype. But for other viruses, there can be cross-reactivity. So, for example, there can be some cross-reactivity between viruses such as dengue virus and Zika virus. There can be cross-react, and particularly for dengue viruses, because there are 4 serotypes. So there are certain viruses where cross-reactivity can be a problem, but other viruses for which that's not a problem at all.
Great, thank you, Bill. I want to turn to Charlotte to ask you, Charlotte, what are your thoughts having listened to the second Q&A, second in a 4-part series? Any additional questions that you might have as an immunization professional?
Okay, thank you very much, Reda. And I've really had quite a it's been a learning experience for me getting to actually know how, what is around organizing a community-based serosurvey. Now, the question that has been going through my mind is what's the profile of the people that could be involved in organizing a serosurvey? Is it just anybody, or, you need some specific skills to be able to take part? And Bill, you could start. Alvira,
yes. Yes, thanks, Charlotte. Serosurveys are complex endeavors. There's no doubt. We don't want to, underestimate the complexity of them. And so they require, actually a team. It's very important to have a team. There's individual skills in the field and data and specimen collection side. So designing the sampling strategy is really important in order to obtain a representative sample so that you can infer from your serosurvey results to the more general population. Some experience and expertise in designing questionnaires is very helpful, so that you collect accurate data on the study participants. Experience and expertise in blood collection and storage and transport is very important. So there's a set of skills on this team around the field and data collection. The specimen and data collection. Then you need a team with expertise or experience in running the assays. Often these are enzyme-linked immunoassays, ELISAs, but there are other types of assays that can be used for serosurveys, and more, hopefully we'll see the use of multiplex bead arrays where we can measure antibodies to multiple different pathogens simultaneously. And then we also need expertise or people on the team with some statistical expertise who can help with the analyses and interpretation of the results. So this is a collaborative team effort with multiple different types of expertise and experience. But these have also been done around the world, and so there's certainly it's not certainly an insurmountable problem, but I also want to emphasize that it does require this type of multidisciplinary team in order to have an accurate serosurvey.
Thank you, Bill. That's it for this part 2 of 4 parts. Join us at this same time tomorrow on the same platform, whether you were watching this on LinkedIn, YouTube, Facebook, Twitter. You will find this must-see television for immunization professionals interested in serosurveys. You can also find on the Geneva Learning Foundation's webpage the workshop we just did with Dr. Anne Lindström from the World Health Organization, focusing on, really for immunization staff in countries, what does the availability of COVID-19 vaccines mean for you, and what is likely to change? What are you going to have to adapt to and learn in order to contribute to your country's introduction of COVID-19 vaccines? Tomorrow we are having this workshop on vaccine confidence with Professor Heidi Larson. So these are activities of the COVID-19 Scholar Peer Hub. And last but not least, I'm super pleased to announce that in the 26th to 28th of January, we'll be holding the Teach to Reach conference. Teach to Reach is a long-time program to improve immunization training. This COVID-19 vaccine introduction is pretty obviously going to be probably the ultimate Teach to Reach challenge, and it'll be the key topic at this conference in January. Look for the registration information to make sure you get your ticket early to join this conference. Now, go to serosurveytools.org to learn more about serosurveys. This is only, I think we're the first to announce and share the information about the availability of this new tool developed by the International Vaccine Access Center. And join us tomorrow, because this is a 4-part series. So Thursday and Friday, you'll find again 15 minutes, maybe a little more if there are good questions. Thank you, GOT Lande, who thanks speakers and the TGLF team. Thank you for joining us. Manoj Kumar, thank you for very useful info. Thanks back to you. And I think that's it for today. Thank you. welcome. If you're joining us now, I'm Reda Sadki from the Geneva Learning Foundation, and we're very happy to be in just a few minutes. Let me check the counter. In 3 minutes and 30 seconds or so, we'll be going live with new members, new cast members in the mini-series on Serosurveys. So Simon and Kyla will be our guests. Simon Mutembo and Kyla Hayford, two distinguished researchers from the international, or affiliated with the International Vaccine Access Center at the Johns Hopkins School of Public Health. So really a team that we've had over successive episodes who are some of the leading researchers on this topic of and practitioners of serosurveys. For those of you who'd like to know more, we'll be sharing lots of resources. We know it's a quick event, but that's the point. We know how busy everyone is, and we hope you'll get enough from this so that if you do want to go further, you know where to go. So that's and we are looking at your comments and questions. We may not be able to get to all the comments and all the questions with Charlotte and Boo. We'll be doing a Q&A first with the IVAC team, and then we'll be looking at your comments and questions. But I already want to acknowledge Ruth Alote connecting from Accra, Ghana, Amel El Tahir connecting from Pakistan, and Ruth says, I'm very excited to be here. So are we, Ruth, and thank you for joining us. See you in just over 2 minutes. Less than a minute, we're getting started. Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki from the Geneva Learning Foundation, and here today with Bill Moss from the International Vaccine Access Center at the Johns Hopkins School of Public Health, together with his esteemed colleagues Kyla Hayford and Simon Mutembo. Welcome to all three of you, and of course with Charlotte Mbu from the Geneva Learning Foundation. How are you doing, Charlotte?
I'm doing great, Reda, and I'm excited. We are already on the third day of our 4-day journey into the world of serosurveys.
Wonderful. So I first want to acknowledge some of the people online who have joined us. First of all, our very own Dr. Tanushree Mandal from West Bengal, India, says this mini-series gets better and better with the passage of the days. This is only episode 3 of 4, but thank you, Tanushree, for that comment. So we've got people on Facebook and YouTube, as well as LinkedIn. Wherever you are most welcome. This is an activity we're carrying out under the umbrella of the COVID-19 Peer Hub, and I recognize many members of the Peer Hub. We are live streaming across LinkedIn, YouTube, Twitter, and Facebook. So wherever it is you're joining us from, please feel welcome. And we are looking at your comments. I see many greetings, and I'm going to go through some of them in a second. I also want to highlight that wherever you found us, you'll also be able to find yesterday's COVID-19 vaccine introduction workshop. It happened yesterday, but you can watch it, and it is very timely. It is about how you, as immunization staff, are likely to be involved in the introduction of COVID-19 vaccines in 2021. Gavi, the Vaccine Alliance, has announced that 2 billion doses vaccines will be available by the end of 2021. This morning, we had the pleasure of working with Professor Heidi Larson from the London School of Hygiene and Tropical Medicine and the Vaccine Confidence Project. She listened to case studies of members of the Peer Hub and gave feedback as well. So we are here now for this 4-part mini-series, and today is part 3. So we're going to introduce our guests. First of all, just a word from Bill to remind us, what is the International Vaccine Access Center, and what is the specific sort of expertise that you have around serosurveys?
Yes, thanks, Rita, and welcome to all of you. We're from the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. We celebrated our 10th anniversary last year, and we really helped to synthesize and build evidence to inform policy and improve access to vaccines around the world. And our team, who you've been hearing from in this mini-series, has expertise in conducting serosurveys. But IVAC is a multidisciplinary team really working on the problem of accelerating global access to life-saving vaccines through building the evidence. And we have economists, we have experts in health communication, we have epidemiologists, infectious disease specialists, a real multidisciplinary team to address this problem. And so I hope you're enjoying this mini-series on serosurveys, and you'll hear from my expert colleagues today.
Thank you, Bill, for this intro. And now, Charlotte, over to you. I'd like to ask you to introduce our guests. And I'm hesitating whether to start with Kyla or Simon. I'll let you choose.
All right, thank you, Reda. I'm actually going to start with Kyla. So please, could you just introduce yourself? Tell us where you work, what you do, and the first time you heard the word serosurvey.
I'm Kyla Hayford. I'm an associate faculty member at Johns Hopkins School of Public Health at IVAC. And the first time I heard the word serosurvey was when I was a young PhD student looking into whether you could use saliva to determine, as a marker of serology, to determine who's protected against measles.
All right. And then what about you, Simon?
Yeah, I'm Simon Mutembo. I'm a medical professional, a medical doctor working as an epidemiologist at the International Vaccine Access Center. The first time I heard about the word serology was during my medical training in Zambia, but I first got involved in the serology work in 2016, working with Kyla, Bill, and Andrea to carry out a serosurvey, which was nested in the post-coverage evaluation survey in Zambia.
Great. Before we go any further, Charlotte, I want to just mark a pause to say hello to some of the folks joining us on across the different platforms. So hello to Jyoti Lande connecting from India, Manoj Kumar from CGPP India. Jyoti is curious about what's new in today's session. And Tanushri Mandal says, so many esteemed speakers and so much to know, very, very informative. I would love to leave all other TV series and better watch this one. Emmanuel Musa is joining us from Kaduna, Nigeria. Martha Ngoe, a accompanist and team leader from the COVID-19 Peer Hub, says, great to be here with great minds. Akinyi Marigoretti says, greetings to all from Kenya. Great to be part of the team. Oruj Ashraf says, hi from Pakistan. Kingston Kamkara from India. Anish Shah from Nepal. And MM Okan says, hi from Nigeria. Back to you, Charlotte.
Thank you very much, Reda. So I'm going to be starting with you, Simon. What are some of the biggest challenges? Because I know it could be challenging organizing community-based serosurvey. So what are some of the biggest challenges in conducting a serosurvey?
Thank you, Charlotte, for that question. So today we'll be talking about the challenges of conducting community serosurveys. The challenges in conducting community serosurveys can range across all the phases of the serosurvey, and these phases are the planning phase, the implementation phase, and then finally the analysis and interpretation of the results. In the planning phase, you need to make sure that you're answering the right questions, you're using the right designs to conduct your serosurvey. In doing this, you need qualified expertise with different specialties. This poses a very big challenge, and you need to address that early enough to make sure that you've got the right staff to be able to do your serosurvey. When you've got the right study design, you've got everything in place, then you move to the field implementation. During field implementation, one of the big things that you should look out is to make sure that you are able to enroll the people that you actually wanted to enroll, and that most of the people that you wanted to enroll do not refuse to take part in the serosurvey, because that will bias your results. To be able to do this, you must engage the stakeholders, you must be able to engage the community. And engagement of the community comes with a lot of challenges. Therefore, you must think about it in the planning phase. You must be able to develop a plan. And I wish to say the plans for engaging the stakeholders and the plans for engaging the community must not carry a one-size-fits-all approach. It should be tailored to the community that you are trying to work with. Once you've got that in place, you have to know that to be able to carry out any type of survey, it requires a lot of resources. By resources, I mean financial resources. There are costs involved. Any survey is expensive to conduct. But for serosurvey, there are additional costs that you should be prepared to incur. You know that you have to buy logistics or supplies for doing the lab work. You must buy the kits. You must pay the laboratory staff. But in addition to that, when you're doing a serosurvey, you have to know that you need to have more time in the field as compared to an ordinary survey. Therefore, even the personnel costs go up. So serosurveys are costly. That is one challenge that you're going to encounter. Once you've done all your field work, you've collected your specimens, you've transported them to the lab. One very important thing you should look out for is you should be able to turn out your results in good time, so that you provide the results to the program managers and they can use them for programmatic decisions. Most of the running of specimens for serology takes a bit of time. That is a big challenge. However, with the COVID-19 serosurveys, we've been able to learn that serosurveys can produce results in good time and be used to make programmatic decisions.
Thank you very much, Simon. And now over to you, Kyla. What are some of the most important sources of bias?
Hi, Charlotte. It's great to talk to you. So I think, we always say that community-based surveys generate the most representative results. And in an ideal circumstance, a community-based or household serosurvey will generate the best unbiased estimate of who is protected in your population. But that only is true if you execute the survey and design the survey properly, and as Simon said, have high participation rates. So bias can happen at any stage in a serosurvey. Bias is any systematic error that affects the representativeness of your results. Like Simon said, it usually happens by if you don't enroll the people that you're attempting to enroll, or the people do not want to participate and refuse. So a good example might be excluding migrant populations. So let's just say you need to know the proportion of kids that are susceptible in a district to measles. And because you want to know if you need to do an additional vaccination campaign in that setting. It's a rural province. There are many migrant workers in that community who live in temporary housing. So one of the risks of bias there is that is that migrant workers in your population have lower vaccination rates, and that they might be more likely to be susceptible to measles. So if you do a survey and design it and don't include the settings where that population lives, you have a risk of underestimating susceptibility in the community. So you have a biased estimate. So it's really important in the planning to make sure you think about, are you attempting to enroll everyone that you're trying to analyze and include in your survey? And then one difference between surveys and serosurveys is there's an added layer of bias on the side of lab testing. So it's very important to make sure your lab testing is done well so that you don't systematically overestimate or systematically underestimate the levels of protection in the community.
Thank you, Kyla. Simon, you mentioned the COVID-19 pandemic. How can we implement a serosurvey during the COVID-19 pandemic, and how do you protect both the participants and the staff?
Yeah. Thank you, Charlotte. That's a very good question. As you may be aware, right now during the COVID pandemic, a number of serosurveys have been conducted, most of them related to COVID-19. Yes, you can do a serosurvey during the COVID-19 pandemic. Bill and I and Kyla and Andrea have been able to do one. But before you can engage in that, you have to ask yourself questions. What is the urgency of what we are doing? How is it going to help with the pandemic? What are the trade-offs? And when you answer those questions, if you decide to go ahead to do the serosurvey during the pandemic, you have to make sure that you protect, firstly, the participants as well as the serosurvey staff. You have to make sure that you abide to all the social distancing guidelines. You have to make sure that you provide personal protective equipment for all the participants, as well as the serosurvey staff. For the serosurvey that we recently conducted at IVAC, we conducted it in Zambia during the period of the pandemic. This is a serosurvey which was nested in the 2020 mass vaccination campaign. We had to make sure that we provide all those things I've mentioned. And one of the lessons we learned was that even simple things like transportation of study participants, we have to make sure that we provide for extra cars so that our study staff are safe, they are not congested. We have to make sure that at the study sites, we arrange the study participants in such a way that they are not congested. If a mother was bringing a child to the health facility during that period has no mask, we had to make sure that we provide the mask. So you have to ensure that you consider the safety of the participants as well as the safety of the study staff. Very key in doing a serosurvey during the pandemic.
Okay, and with all of this, what can possibly go wrong?
Yeah, in implementing serosurveys, a lot of things can go wrong. And these things which can go wrong at all different phases of the serosurvey, during the planning phase, during the implementation phase, and during the analysis of the lab specimens, as well as analysis of the lab results. One thing I would want to caution or talk about is to make sure that you respect the person. When you're doing a serosurvey, you have to respect the person. You have to make sure that the information you're collecting is treated confidentially. You have to make sure that the storage of the specimen which that person has given you is done correctly. You have to make sure that the analysis of that specimen is done meticulously, and you must make sure that the people handling the data are looking at the data, reviewing it, and making sure that you are collecting the correct piece of information which will be able to address the research question that you are talking about. If you do that, you'll be able to avoid all the things that can go wrong during specimen collection, and things that can go wrong during the data analysis.
Thank you, Simon. My last question is for you, Kyla. What questions have you been able, you as IVAC, have you been able to answer using serosurveys?
So this is a good question, and there are many questions that many different groups have been able to answer in using serosurveys. Today, I will focus on some of the things that we've learned. And at a very high level, we've learned about how to do serosurveys and how to do them well in an unbiased way to answer the questions that are important for immunization programs. So like we mentioned earlier, we want to make sure we're conveying what we've learned to professionals around the world who are also doing serosurveys. And much of what we've learned focusing on serosurveys for vaccine preventable diseases is directly relevant to serosurveys for SARS-CoV-2, right? How you do it and in the field and back in the laboratory is directly translatable. So a couple, I want to highlight two things that I think have been really important learnings for us with serosurveys. In Zambia, we did a serosurvey after a measles and rubella campaign. And what we learned there was that, we confirmed that the prevalence or the protection against measles and rubella was extremely high in children who were eligible for the campaign. It was a great indication and support of that the campaign was effective. But we also enrolled people who are older than the campaign age range. So that's important because post-campaign coverage surveys are focused on kids who got the campaign. And we wanted to say, well, what about the whole population? Who are people above the age of 15 years protected or susceptible to measles and rubella? And what we learned from our serosurvey was that, in fact, there was a small immunity gap in individuals who are just above the age of the campaign, 16 to 30 years old, particularly among women, to rubella. So suggesting there's an immunity gap to rubella at that age group. And that's important to know because, as many of the professionals in this group listening to the call know, that rubella immunity is very important for women of reproductive age. So that was one thing that was really illuminating for us. Another important thing we've learned is in India, they did the largest measles and rubella vaccination campaign in the world in the past few years. And everyone wants to know, what was the impact of that campaign? Are the children protected because of it? And we were through serosurveys that we conducted before the campaign and then after the campaign, we were able to directly evaluate the impact of the campaign on protection for measles and rubella. So it was really illuminating and an interesting way to evaluate how to do serosurveys around the world.
Thank you, Kyla and Simon, for answering my questions. Right now, I'm going to turn over to Reda for comments or questions that could be coming from our various social media platforms. Over to you, Reda.
Great. All right. Thank you, Charlotte. We've got a lot going on and some really good questions, actually, from people who I know were there on the previous days and following along with this mini-series that we're doing the Geneva Learning Foundation with, and thanks to the International Vaccine Access Center and the experts that are contributing today. So let's start with, let me go back to the first question. Well, actually, I first want to acknowledge that I'm really happy Abidemi Olatunde, who's joining us from Facebook, who logged in, who couldn't find us yesterday, and she's now been able to connect. And I hope, Abidemi, that you'll find this interesting and useful. So, I have a question from Marta Ngoe that actually, I don't know, I hope you can see this. I'm going to read it. So she says, currently in Cameroon, sample collection for serosurvey is going on in all 10 regions for the COVID, which will, which will end by the 30th of December. The major challenge here is obtaining the consent of caregivers for children under 5 to be enrolled into the study. This may give room for some sort of bias. What can be done to minimize this bias?
I can begin. I think the most important thing is to start by building strong connections with the community, with the key stakeholders in that community, which I'm sure you've been doing. And it's always a sensitive conversation to request blood from a young child who is healthy. So that you have to do the best you can in building those communities. It's true there could be a risk of bias because the younger children will be underestimated. I think it's documenting how many people refuse, what their ages were, so that you know where your missingness is, and then you can better understand, were those missing people who you didn't get data from, were they more likely to be protected exposed to SARS-CoV-2 than the people who were enrolled in your study?
Simon, would you like to complement that?
Yes, the most important thing, like Kyla said, is to make sure that you engage the people. It's always very challenging to enroll children who are young. In most of the serosurveys, there are a lot of suspicions. People talk about satanism, but you cannot overemphasize the idea of engaging the community and getting the information that you need. The other important aspect, which Kyle has also mentioned too, is the fact that we have to make sure that you collect information on the people who are refusing, so that you are able to, when doing your analysis, you consider that information in your analysis.
All right, thank you. The next question is from Manoj Kumar Shudari via YouTube. So Manoj Kumar just wants to know, what are the guidelines to inform the result of a specimen test to individual survey participants?
This is a really challenging and important question to ask. So I can start, and I will not be able to answer all of it. But I think the most important things to consider here are, what is the information you're collecting, and what results will you have? When will you have them, and can you get them back to the person in a timely manner? How important is it, and how will it affect the person's decision-making, safety, and well-being to know that answer? And then how are the tests appropriate for sharing individual results? So for instance, in Zambia, the tests that we use to evaluate protection against measles and rubella are population-level tests. They're not designed to diagnose who is susceptible and who is protected at an individual level. So what we do is we share those results back to the district health work, or the district community staff, to the EPI program, but we are not able to share them back to individuals because of the limitations of the test. But this might be different if you were doing, for instance, if you were doing HIV testing. It would be unethical not to share that information. So I think there are a lot of considerations to look into.
And Simon?
So the sharing of results is always a very big concern. So you must understand, when you're doing a serosurvey, the kind of test you're using. Is it for diagnostic purposes, or is it something which you're using to make a community diagnosis? For both cases, if it's something diagnostic where you must intervene, you have to make sure that the results are communicated back. Kyla uses the example of HIV, where you must intervene. If it's for community diagnosis, even then you must be able to explain that, to communicate the results back to that community, but will not be able to share the individual results because they will not be used for any clinical interventions. But it is very important that you share the results with the community where you've collected that data, where you've carried out the serosurvey one way or the other.
Thanks. So actually, Abidemi Olatunde I remember her message now yesterday, and she had a question, which and it is the following: do people receiving the COVID-19 immunization react to it negatively? So it's natural, given the current context, that there would be questions about COVID-19 vaccines, not strictly speaking within the scope of serosurveys, but because we have three experts, I'd like to turn to Bill and just ask him to give a quick, if it's possible, to give a quick answer to that question.
And Reda, maybe I had a similar question in mind, just to ask, in their experience of organizing serosurveys, have they had communities that were hesitant to vaccination, also hesitant to accepting the serosurveys, and how were they able to handle that?
All right, Bill, would you like to?
Yes, Rita, thank you. I'll take the question around the COVID-19 vaccine. So obviously we know the most around the messenger RNA vaccines, the Pfizer and Moderna vaccines. There are several types of adverse reactions we've seen. By far the most common is what we call reactogenicity that many of the listeners will be aware of. This includes soreness at the site of injection, some headache, muscle aches, joint pain, fatigue. Some people have fever. This happens within 12 to 36 hours after the vaccination as part of the inflammatory response. We have heard about, first in the UK and then most recently in the United States, some individuals have a more severe allergic reaction, what we call an anaphylactic reaction, that has required treatment. This is very rare. We're still trying to figure out what component of the vaccine is inducing this type of reaction. We don't know that yet. So those are the two kind of types of reactions: the reactogenicity, transient, no long-term consequences. People are a little more concerned about these more severe allergic reactions, but it hasn't necessitated a pause or stopping in the vaccination programs.
Thank you, Bill, for that answer. That's really an aside. Technically speaking, we're outside the scope of today's topic for part 3 of this mini-series, which is really looking at challenges with community-based serosurveys. But Abidemi, because you came back after yesterday, and Bill is probably one of the best people in the world, the most capable people to answer a question like that, we're happy to ask. Now, back to the regular programming and back to the questions that are piling up in the comments. Thank you so much. I'm afraid we're not going to be able to address everything. Tanushri Mondal alone has 3 questions. Before I get to them, we have a question from Ocon who says, are there legal considerations in sample collection? Let's do Kyla and then Simon.
Well, I think in all research studies, we always use informed consent and ensure that we have proper consent from participants or caretakers. So from a legal perspective, we always follow the highest standards for human subjects research. And I think that is important to ensure you do that, whether you're doing it within the frame of a research project or in the frame of for immunization surveillance.
All right. Simon, is there anything you'd like to add to that?
In terms of specimens, we have to make sure that we abide to the highest ethical standards. Like I mentioned earlier on, you have to respect the person who has committed himself or herself to donating that specimen to your study. So we abide to all the ethical regulations, make sure that we maintain the confidentiality of the person who has donated the specimen. We meet all the standards that are required. If the specimen is required to be destroyed after doing the test that we do, we make sure that we do that. So you have to comply to all the standards that are stipulated in the ethical approval that you get when you're working with specimens.
Great, thank you both. All right, we're obviously way over time here, but obviously there's some really good questions here. Adamu Abubakar from Bauchi, Nigeria says hello to everyone. Now, I'll give you sort of rapid fire Dr. Tanushri Mondal's 3 questions. Question 1, what has been the experience of IVAC in securing consent of people in community serosurveys? 2, what was the objective behind the serosurvey in Zambia during the pandemic? And 3, what are the inclusion and exclusion criteria for such serosurveys, and specifically the one done in Zambia? So we'll turn to you with these 3 rapid-fire questions, and then call it a day for this third episode in this 4-part mini-series. Kyla, and then Simon.
I'll answer question 1 and pass 2 and 3 to Simon. So with consent, we actually had pretty high enrollment and participation rates, and that's in large part because of the engagement of the organizations that already knew those communities that did the data collection, and also the extensive community engagement and stakeholder engagement we did. So generally positive, but very important just to make sure the parent or the participant understands the purpose and understands how their specimens and their data will be used.
Now, to answer the second and third question, let me give a context first. Zambia is in the process of moving away from doing mass vaccination campaigns every 4 or 5 years to targeted mass vaccination campaigns. And this year we were holding a mass vaccination campaign for measles and rubella. So the research question that we are trying to answer in this mass vaccination campaign, which was conducted during the pandemic, was mass vaccination campaigns capturing children who are susceptible to measles and rubella. The only opportunity we had to answer this question was during this mass vaccination campaign. And we need this piece of information for us to be able to make the decision whether the country should move away from nationwide mass vaccination campaign to targeted mass vaccination campaign. So this was very critical information, and this information can only be collected during this period. Hence the reason for conducting this serosurvey during the pandemic. However, I should be able to say that we had to make sure that we comply to very high standards to ensure that we protect the safety of the participants as well as the serosurvey staff.
All right, thank you. Thank you both. Thank you, Bill Moss from the International Vaccine Access Center. So this was a kind of double episode of our mini-series on the serosurveys with the International Vaccine Access Center. I'd like to conclude by pointing participants to the serosurveytools.org website that has been established by the team at IVAC. Probably currently the best, most comprehensive resource. That's not boasting, that's just a fact. Would you agree with that?
Oh. Yes, thank you, Rita.
All right. So definitely go look at that if you'd like to go beyond what we're able to provide in a few minutes in the live session. For those of you who are looking for reliable information about COVID-19 vaccines, I would also recommend you look at the communication being issued by the International Vaccine Access Center and the Johns Hopkins School of Public Health are certainly a reliable source, as well as, of course, the WHO, the World Health Organization resources to find answers to questions like these. WHO is doing live sessions pretty much every day and reinforcing, strengthening their communication. So if you're an immunization professional, you have sort of general questions about the pandemic, this is not the place to come ask them. We're really specifically focused on serosurveys, but we understand the questions are there. And in fact, we're also doing a number of other events. You can, if you go to our Facebook page, you'll find the page on COVID-19 vaccine introduction. This was with Anne Lindstrand from the World Health Organization. We just finished this morning, specifically really deep diving on vaccine confidence, demand promotion, vaccine hesitancy. And then we're super pleased that tomorrow will be the fourth part of our mini-series with the great team from IVAC. So that's it for today. I have one last special announcement for those of you who are still online watching this to the end, and that is the announcement about the Teach to Reach conference. We'll be announcing this, and you'll be receiving, if you're on our mailing list, you'll be receiving the invitation to register for this conference, bringing together global partners together with immunization staff from all over the world. How do we learn and adapt during the pandemic? The COVID-19 vaccine introduction is basically the ultimate Teach to Reach challenge, and we're hoping to bring together many of the partners and many people from countries around these topics. Thank you for having joined us today. That's it with this almost triple episode. I'm going to do a rewind of all of the questions and comments that came in. There were more questions and more participants today than in the previous episode, so that's a good sign. Thank you and goodbye.
fourth video. If that's okay.
Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki from the Geneva Learning Foundation, and I am here with 4 experts from the International Vaccine Access Center, known as IVAC, with Bill Moss, the director, and colleagues Kyla Hayford, Andrea Carson, and Christine Prosperi. Today we are speaking about the 4th episode here around the topic of serosurveys, and today we're looking at alternatives to community-based serosurveys. And I hear one person who has noise in the background. I think it is Charlotte. Charlotte, how are you doing?
Thank you, Reda. I'm doing great, and it's great to have our experts from IVAC with us for this 4th day of this journey that we took upon serosurveys.
Great, thank you. All right, let's dive in. First, we need the reminder from Bill Moss, the director of IVAC. What exactly is IVAC, and what are you doing what have you been doing around serosurveys lately?
Yeah, thank you very much, Reda. And we're very excited to conclude this mini-series on serosurveys. The International Vaccine Access Center is based at the Johns Hopkins Bloomberg School of Public Health. And we're a multidisciplinary team that has as a mission to accelerate global access to life-saving vaccines through the development and implementation of evidence-based policies. And some of us, Reda, at a small team of us at IVAC have been working on serosurveys to better understand their utility and feasibility. And we're really excited to share with your audience some of what we've learned over the past several years in conducting serosurveys in Zambia and in India.
Great. Okay, great. And I believe one of the things we want to highlight, if you're joining this live session now, is to go look at the serosurveytools.org website. In addition to listening to this mini-series and learning more, if you want to go further, this is probably, Bill, would you agree that this is potentially probably one of the best resources available online about serosurveys?
Yes, Reda, thank you. And there are documents out there. The World Health Organization has produced documents, but what we've tried to do is really make learning modules and provide tools for people who are interested in learning more about serosurveys and actually conducting serosurveys.
Great, and I just want to acknowledge some of the folks who are joining us online, such as let me see. Abubakar Mohammed, who is joining us from Nigeria. Welcome to you, Mohammed. And without any further ado, let's dig into the questions. So Charlotte will take us first through a Q&A, and then we are keeping an eye out for comments and reactions. There may be a technical glitch today that prevents us from looking at the comments. So please let us know you're there, type in the city and country, and share your questions as soon as you have them. I see we may be recovering from the technical glitch because I see messages from Ahmed Sanga and from our very own Dr. Tanushri Mandal from the COVID-19 Peer Hub. So Charlotte, over to you to walk us through the questions for today's episode, fourth and final episode in this mini-series on serosurveys.
Thank you very much, Reda. My first question is addressed to you, Kyla. And why would you choose not to do a community-based serosurvey? For the past few days, you have been talking about community-based serosurvey. So why would you choose not to do that?
Thanks, Charlotte. It's great to be back. And as we talked about yesterday, there are lots of challenges to community-based serosurveys, but I do want to highlight that if you want to get a representative estimate for your population with the least bias, then the best way to do it is with a community-based serosurvey, if you do it well. Also, another strength is that you can collect specimens in a community serosurvey, and you have full control over who's included in the survey, how you design the study, to be able to answer the question you want to answer. But oftentimes that's not feasible. And briefly, there are three main reasons I think of that you would not choose to do a community-based serosurvey, and you would choose to do an alternative study design. And so the first is cost. So yesterday, Simon Mutembo highlighted that community serosurveys are expensive, and there are alternative designs that can lower the cost substantially, particularly by removing the cost of fieldwork. The second reason you might not do a community serosurvey is time. So we know from planning the serosurvey to data collection to data analysis, it takes a lot of time. So if you need answers about seroprevalence very soon, and an example would be the SARS-CoV-2 serosurveys, an alternative study design might be best if you're able to answer the question you need to answer. And then maybe the third reason is that you wouldn't do a community serosurvey is just the effort it takes and the importance of sustainability of that method in the future. So if your goal is to set up a more sustainable long-term surveillance system, then there are better designs than community serosurveys to do this.
Thank you, Kyla. My next question is for Andrea. Andrea, what are the most common alternative study designs that could be used other than community-based serosurveys?
Yeah, thank you, Charlotte. So at the high level, I think, as Kyla mentioned, for community-based serosurveys, you're going out and you're collecting new specimens. So when we think of alternative study designs, we try to look at where are there specimens that have already been collected, right? So some examples would be either a biorepository that might exist with specimens either from another survey or, for example, a blood bank. And another option could be to use residual blood that's being collected either in a lab or a clinic that might have leftover specimens after the original testing is complete. So we know that people come and they get their blood drawn to test for some routine things like iron levels, and there might be some blood remaining that you could use as an alternative.
Kyla, could you tell me how you will use residual or leftover blood in a serosurvey?
Sure. So with leftover residual blood, like Andrea said, so at a clinic, if the tests have already been completed for the reason that the blood was collected, this blood might be thrown out. We have looked into various ways of doing this. And this is a really important area of research for IVAC because our goal is to understand how to improve the utility and feasibility of serosurveys around the world. So one approach that we've done is in Zambia, there was a massive, extensive biorepository collected for the FIA studies, or the ZAMFIA project, which was estimating HIV prevalence throughout the country. It was a nationally representative survey, ideal setting. All the specimens had been collected. There was ethical approval to use those specimens for additional testing. And so we were able to partner with the ministry and test the residual blood for antibodies to measles and rubella to understand seroprevalence in the country and levels of protection against measles and rubella. So that's a very unique circumstance. And if there are biorepositories available where you work, it's worth looking into them. Second, what might be more common is accessing residual blood from a clinic or a laboratory. And in India, where our team has worked, we wanted to look at, could you evaluate the impact of a measles and rubella vaccination campaign on seroprevalence? How much did the seroprevalence increase after a vaccination campaign by using easier to access blood? And so in that case, we worked with the district health facilities and collected leftover blood from both pediatric and adult specimens, and were able to test those blood specimens. So those are two highlights of alternative designs that have worked very well.
Thank you very much, Kyla. What are some considerations for using residual blood from a hospital or laboratory for a serosurvey? This one's for you, Andrea.
Sure. Yeah, so I think as Kyla mentioned, we were able to do this in India, but I think the key aspect when you're considering this type of study design really is, what is the study question that you're trying to answer? And using that, then you can think about, is there a lab or a clinic that has leftover blood that would be appropriate to use to answer that study question? The challenge is that we're usually looking to sample from people that would reflect the general population. However, the people that are going to a lab or a clinic are often going because they're sick and they're not necessarily healthy. So we need to make sure that they represent the population that we're trying to sample from. So for example, one common source in many countries is to use residual blood from antenatal care clinics because pregnant women are having their blood drawn for routine preventive care and otherwise might be generally healthy and represent the general population. So for example, if we're interested in assessing the susceptibility of adults to rubella or to tetanus, these antenatal care clinics would be a good source. By contrast, when we're trying to study children, it's a little bit more challenging to find a representative sample because children tend to only have their blood drawn when they're ill. So these are just some things to think about when you're trying to use a lab or clinic for residual specimens.
Thank you, Andrea. And talking about residual blood from a lab or a clinic, Kyla, what are the most important challenges you think of when you do that, and what could be the implications for the results?
I would underscore what Andrea just said, and that I think the most important challenge in finding sources of blood specimens for serosurveys is ensuring that those blood specimens represent the population that you want to study. So you need to ask yourself, what is the population that I'm interested in? And then if, let's say, you're going to work in a district hospital where there's blood from the serology lab, do those samples that you can access represent the population you're interested in? How might they be biased? Who do they exclude? Why were those specimens originally collected? And one thing to really consider is, if they were collected for a reason that was related to the outcome of your serosurvey, you might not want to focus on that population. So for instance, we know HIV positive individuals, there's an association between HIV status and measles serostatus. And so if you're working in an HIV clinic, collecting residual blood from there, you may not get a representative estimate of measles seroprevalence by working in that clinic. And you may want to have a broader range of the population. Another challenge just to keep in mind when considering residual blood is that you cannot get all of the data you would normally get if you did your own standalone serosurvey. So often you can only get age, maybe gender, and often that's enough, but I just want to highlight that you're not going to usually get vaccination history data or maybe other socio-demographic characteristics that could be important for your analysis. So consider that. And maybe the last issue to think about for challenges, which is also a benefit, is that you need to integrate within the healthcare system. So it can be challenging because you don't want to take people away from their primary responsibility of taking care of their patients. But if you can set up a system that's sustainable, then it's more likely to continue and be lower cost.
Okay. Thank you, Kyla. My last question is for you, Andrea. What are the ethical issues of using residual blood? We had lots of questions yesterday on ethics.
Andrea is
Andrea, please, you're muted.
Sorry, yes, I was on mute. So I think one of the biggest considerations that Kyla mentioned earlier is that in order to do any testing on someone's specimens, you would need to ensure that there's permission and consent, right, to do the testing. So if you're using residual blood, you'd need to make sure that there was the additional permissions that allowed for testing beyond the original intent. So I think that's really the primary one to ensure you have before you can access a residual specimen. The other thing Kyla just noted, often you don't have all of the information for that specimen. So it might be anonymized, which means you wouldn't be able to report any results back to the participant. So you'd want to make sure that whatever you are testing for isn't something that would be that would affect the participant's health. So for example, you probably would not use residual specimens to test for HIV because this is something that you would need to report back to the participant to ensure that they're enrolled in treatment if they were to test positive. And these ethical issues can be addressed in partnership with the whatever lab or clinic and the system that you set up. As Kyla mentioned, I think working closely with the lab or clinic and really integrating with them, they understand best what are the implications for their populations. So those are two things to think about, but we could expand more if there's additional interest in other ethical questions.
All right. Thank you very much, Kyla and Andrea, for answering my questions. Over to you, Reda.
Great. Thank you, Charlotte, and thank you, panelists from IVAC, or I should say cast members from the International Vaccine Access Center. All right, there's been quite a bit going on Facebook and YouTube today. I think there may have been a glitch on LinkedIn, but that is less important than the fact that we have some regulars, and I want to share their comments with you, with the IVAC team. I also want to open up for questions. So if you have questions in relation to serosurveys, and specifically, even better, if they're with respect to today's episode, alternatives to community-based serosurveys, please type them into the comments, whether you're on Facebook, YouTube, or anywhere else. I do want to share, and it's actually this, I'm going to put the panelists on just to acknowledge some of the comments we've been receiving. So let's see, we've got, and I see some names that we've seen that were also with us during previous episodes. So Daniel Haruna from Abuja, Nigeria. Hello to you and thanks. I hope you're still with us and that you have you're typing in some good questions. Ruth Olote connecting from Accra. Our very own Tanushri Mandal, who says, loving the Serosurvey series. therefore, sorry, this is the last episode. Wish more to come in the future days. Dr. Puran Sharma from Darjeeling in West Bengal, India. Amel El-Tahir connecting from Pakistan. Mercy Onu-Peters, who's also been on other episodes. Tanushree says, I was very pleased to know about the serosurveys done pre and post MR campaign in India and the objective of doing serosurveys in Zambia. Wonderfully explained. So that's feedback for the panel. Burema Kabore from Burkina Faso has joined us, as well as Dorothy Lojedi from Kenya. Joel Kudu connecting from Ivory Coast, and Mary Goretti Akini from Kenya. The 4-part series is awesome. I have gathered a lot from the presentations. Thank you. And do tell us also, praise is nice. If you see ways in which we could improve, that's also much appreciated. Dr. Eke Hudu from Abuja, welcome to you. Dr. Abidemi Olatunde, who's back today. This is good afternoon. Good to be here. Endayo Iwat, unfortunately, I'm not going to show your message because you have included some personal information in your message. Abdeladif also says, great presentation. Now, we have a first question from Tanushree Mandal, and I encourage you to type into the comments. Put in your questions. We're going to be sharing them with the panelists. We only have we're already over time. We're going to take a few minutes to see what questions are coming in today. Tanushree wants to know, for serosurveys, what is the sampling method employed? Yes, and she's typed in her question from Facebook and YouTube. So what say you, panelists, in answer
I can
to
get
that
started.
All right.
And so I think there's two different approaches. So one, the community-based serosurveys, the sampling method, we would recommend following the WHO cluster survey manual guidelines for doing multi-stage surveys, and they're directly applicable to serosurveys. Now, for alternative study designs, like using specimens from a leftover at a clinic, you can't choose how many samples you get. You get the samples that are available in the time frame that you need to work. So what you really need to do, I would recommend that you learn about the clinics where you think you may be able to work, identify how many specimens are collected each day, what's the rate of collection, what's the age group, and so you understand how quickly you would be able to accumulate your specimens, and then evaluate for your classic sample size calculations, can you answer the question you want to answer with the precision that you're hoping for in the time frame that you have working with that clinic. And you may increase the number of clinics you work with if it's insufficient.
Great. Any additional comments, details on what sampling method is employed for serosurveys? And again, the reference to the WHO cluster survey manual, type that into Google. You should be able to find the full manual is available from the WHO website. Any additional comments or details to add in response to Tanushree's question?
Maybe I'll just add, Kyla talked about if you're trying to work in the lab or clinic. I think the other study design we've talked about today is using a biorepository. So there, your cap is obviously the entire biorepository, but you can subsample based on, as Kyla noted, doing a classic sample size calculation with what is the precision that you want, what's the point estimate that you're trying to get, and then identify whether that biorepository has sufficient samples for you to be able to answer the question you're looking for.
Great, thank you. So we have another question. This one is from Mercy Onu-Peters, who asks, can serosurveys be classified as e-health or m-health?
Maybe I'm going to ask you, Rada, can you distinguish e-health and m-health for me?
I'm not sure. Mercy, can you tell us? So there's a slight delay, so we won't be getting the answer from her right away. But that's, I believe it's mobile and sort of digital or electronic, right? So one could be electronic, but not while being stationary in an office on a computer. I get Mercy, if you can tell us in the comments And I also want to acknowledge other folks who've joined us. Tahami Rabiu Abdullahi, Anish Shah, who says, hello, everyone. Tahami actually says, nice to meet you. Nice to meet you as well, Tahami. Glad you can join us for this final episode. And Abdul Arif just says, thanks. All right, looks like, Mary Goretti Akini says, tell me if you consider the blood group when sampling.
I can start. That is a good question.
I was going to say, that sounds like a Kyla question.
We have not assessed blood group because we don't consider it and are not aware of any that it's a risk factor for affecting the outcomes that we're interested in, measles and rubella or tetanus seroprevalence. However, in experiences working in Kenya and Mozambique, there's often an interest in the participants finding out what their blood group is as part of the process. So that may happen, but for research purposes, we have never used blood group.
All right, thank you. Been a great panel, a great cast of characters for this mini-series. The first time we've ever done anything like this. This time on Serosurveys in collaboration with the International Vaccine Access Center that is really a center of excellence in this area and has just issued the Serosurvey tools. So that's serosurveytools.org website. Quite an important resource if you're interested in this topic and would like to go further. I'd also like to point those of you who are watching online who have not yet attended the special event that we did in the summer. We've been rerunning it, and you can catch the next showing at 4 p.m. today, Geneva. If you go to learning.foundation and then go to special events, you'll find the Serosurvey special event. There's also a list of resources. You'll recognize some of the some in the cast from the mini-series were also in the special event. And then here you have what's really important is here you have a list of references with links so you can find more if you'd like to explore further. That's it for today. Thank you. And this wraps up our 4-part mini-series. Let us know what you thought of this experiment. And thank you, Bill Moss, Kyla Hayford, Andrea Sarkellen, Simon Mutombo, and Elvira Hassan for being a part of this and helping to share your expertise on this topic. Final comments from each of you before we go? Will do.
We want to thank you, Rita, and the Geneva Learning Foundation, and for your wide network for participating in this. And we are looking forward to future lightning talks on serosurveys.
Great. All right. Thank you so much. And for those of you watching online, we know we'll see you soon, and look forward to keep engaging in this conversation, this type of dialogue. Let us know what you found most useful about it. Thank you. Now we'll do the rewind of the comments, some of the comments received today.